So the first thing that I'm going to do is demonstrate two tests that test for sacroiliac dysfunction. And the first test that I'm going to do is the anterior stress distraction test. That is going to have a positive test, is going to be the reproduction of SI symptoms. And the test has a high specificity, which means that if you get a positive test, we're going to rule in for SI dysfunction. So the first thing that I'm going to do is palpate for his ASISs, and I have them right here. I'm going to take each of my thenar eminences and cross my arms and try to maintain good body mechanics here. And I'm going to apply a laterally directed force to either ASIS in order to gap the anterior aspect of the sacroiliac spine and compress the posterior aspect. And again, a positive test that I'm looking for is a reproduction of symptoms. So one more time, that looks like that. So the second test we're going to do for sacroiliac dysfunction is called the posterior SI stress compression test. And it does have a high specificity, so if it's positive, we're going to rule in for SI joint dysfunction, and a positive test is going to be the reproduction of those SI pain and symptoms. And we're going to go ahead and again palpate for that ASIS, and I have it right there, and make sure to have good body mechanics. I'm going to place my hands, both of them, over the anterior kind of lateral aspect of the ASIS, and place both of my hands over there, and then apply a medially directed force this time to gap the posterior SI joint and compress the anterior SI joint. And again, a positive test is going to be the reproduction of those pain and symptoms. So the next two tests we're going to do are going to test for an acetabular labral tear. And I'm going to choose to do the anterior labral test and the posterior labral test, both termed the FitzGerald test. For the anterior labral test, the test has a higher sensitivity than specificity, so if it's negative, we can rule out an anterior labral tear. A positive test is going to be for snapping and clicking, where we are going to put her in a position of flexion, abduction, and external rotation. First, I'm going to walk her through the range of motion so she knows what to expect. And that's going to look like abduction, extension, and internal rotation. Now, I'm going to put her in that starting position, abduction, flexion, and external rotation. I'm going to ask her to push into my hand. Push, 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 push. Awesome. So if she had pain, clicking, or snapping with that motion, she would be positive for an anterior labral tear. So the next test we're going to do for a labral tear is going to be the posterior labral test, also called the FitzGerald test. It has, again, a higher sensitivity than specificity, so if it's a negative test, we can rule out a labral tear. If it's positive, another test should be done. The same here for the last test, where a positive is going to be pain, snapping, or clicking. So for the range of motion, I'm going to go ahead and start her in full flexion, abduction, and internal rotation. Bring her around to go into abduction, extension, and external rotation. To provide resistance here, I have her in that same starting position of flexion, abduction, and internal rotation, and I'd ask her to go ahead and push into my hand. Push, 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 push. Awesome. To go ahead and get into that end position there of extension, abduction, and external rotation. And again, a positive test is going to be pain, snapping, or clicking. So the next two tests that we're going to do are going to be to assess for patellofemoral dysfunction. The first test that we're going to do is called the eccentric step test. And the eccentric step test is going to be positive if the patient has pain or mechanical symptoms in the retropatellar space. As far as utility goes, the Cook article referenced on Web Courses stated that this test has a high positive LR ratio. Now, in order to kind of do the test, I'm going to come over to my patient here. In a clinical setting, I would make sure that there was some kind of something that he could grab or hold on to, just for safety reasons in case something were to happen. But for now, I'm going to be the one stabilizing him, and I'll be here if he needs me. So what I'm going to have him do is his right leg is the involved leg and his left leg is the uninvolved leg. I'm going to have him take a step off of the step with the uninvolved leg to put pressure and weight on that involved leg to see if it can elicit symptoms. So I'm going to go ahead and have you pick up your left foot and step all the way down and then step down. And if he had pain or mechanical symptoms in the retropatellar space, he would be positive for patellofemoral dysfunction. So the next test we're going to do for patellofemoral dysfunction is called the Waldron test. So the Waldron test, a positive test, is going to be pain in the patellofemoral joint or crepitus. As far as utility goes, there was an article cited in Dutton that said the positive and negative likelihood ratios for this test were unimpressive. However, the Clark and Zoller tests were mentioned in class to have poor utility, so I chose to do this test. But what I'm going to do is put him in flexion, and I'm going to take my hand and compress it into the patellofemoral space and move him from flexion 2 extension, back to flexion, still compressing, 2 extension, and again, I'm looking for that pain and crepitus when I move through that dynamic motion there. So the next 2 tests we're going to do are going to be testing for plica syndrome, and the first test we're going to do is the medial plica test. Now, the positive test for this test is going to be painful snapping and clicking, and the utility for this test is going to be good because the most common place for a patient to have plica is on the medial side. I'm going to go ahead and put him in slight flexion here while I'm getting him ready. I'm going to take my thenar eminence and apply a lateral to medial directed force, internally rotating the tibia, and then moving him from flexion to extension, again looking for that painful snapping and clicking to elicit, which means that the patient may be positive for plica syndrome. So the next test we're going to do for plica syndrome is the medial plica shelf test. A positive test is going to be an audible snapping or clicking that may be painful. The utility for this test, again, is going to be good since the most common place for a patient to have plica syndrome is on that medial aspect. I do have his leg bolstered about 20 to 30 degrees, and I'm going to take the base of my hand and my thenar eminence and apply a lateral to medial directed force here to see again if that elicits a painful response such as snapping or clicking. So the next test we're going to do is going to be testing for inversion ankle sprain, and I'm going to choose to do the anterior drawer test for the ATFL. Now, a positive test is going to be anterior translation compared to the contralateral side, laxity, and pain. Now, as far as diagnostic utility, this test does have a high rate of false positives, but I chose it because the ATFL is commonly injured with an inversion ankle sprain. I have him here with one of his feet underneath his opposite knee, and I'm going to stabilize with my web space over the distal tibia-fibula articulation with my thumb able to kind of palpate that ATFL ligament and my opposite hand grasping the calcaneus. I am going to shift his calcaneus forward in that kind of oblique plane since we have him at about 20 degrees of resting plantar flexion here, and kind of pull him forward. And again, I would be looking for pain, laxity, and increased anterior translation compared to the contralateral side. So I'm going to go ahead and have him switch feet. And if I saw a difference from one leg to the other, I would say he would be positive for an inversion ankle sprain. So the next thing we're going to be testing for is Morton's neuroma or interdigital neuroma, and I'm going to choose to do the Morton's neuroma test. So a positive test is going to be a reproduction of neurological symptoms. Neither Ortho notes nor Dutton had any diagnostic accuracy information for this test, but it's the only one for this particular diagnosis, so that's why I chose to do it. And have his foot hanging off the edge here, and I'm going to take my thumbs and either side of the web space between my fingers around his foot, kind of where his metatarsals are there, and I'm going to squeeze, not shear, just squeeze them to see if there's a reproduction of those neurological symptoms. Now, it has to be neurological symptoms. If it's just pain, it might be like a stress fracture or something, and it's more on that fifth side, he may be positive for an avulsion fracture, Jones fracture. Most commonly, Morton's neuroma, it's going to be between those second and third metatarsals with neurological symptoms. So the next test we're going to do is to assess for foot arch structure and mobility, and I'm going to choose to do the navicular drop test. So the diagnostic utility was actually not mentioned in Dutton for this one, but a positive test is going to be a greater than 10 millimeter drop when the patient moves from kind of a subtalar joint neutral to a weight-bearing position. I'm going to go ahead and make 3 marks, one on the medial malleoli, and then I'm going to palpate for that navicular tubercle there, and we're going to draw a dot there. And then I'll also do kind of the middle of the head of the first metatarsal. And now I'm going to take the back of her leg here and kind of pronate and supinate the foot if she lets me relax. There we go. Kind of palpate those equal parts of the talus, and I'm going to set her foot back down so she's in that subtalar joint neutral position. I'm going to take my index card on that dot on the navicular tubercle and draw my line right there. And then I'm going to go ahead and ask that she stands up. And I'm going to take my index card again and draw where that dot is. And then I'm going to take my ruler here. She has about exactly 1 centimeter or 10 millimeters of a drop. So that would indicate that she has a little bit of a navicular drop, but since a positive test is 10 millimeters or more, she's right on the border there.